We're live.
Thank you. And good afternoon, everyone. Welcome to my fellow commissioners and to those in the public that are joining us via live stream. Let me take a moment to walk you through our agenda and plan for this afternoon. At the start of the meeting today, we're going to take 2 board operations votes, and then we will vote to enter a confidential executive session. That executive session is expected to last approximately 1 hour. So we'll look forward to the board rejoining the live stream at approximately 1 p.m. and we'll then cover the public portion of the agenda. When we return to the public portion, we'll start by reviewing the 2023 Performance Improvement Plan process and hear an update on the status of the performance improvement plan that we've had in place with Mass General Brigham. We will then move to staff providing an update on notices of material change that we've received since the last board meeting, including the filing by Stewart Optum. And the board is going to review and discuss potential policy solutions to address the rising influence of private equity in healthcare. We'll then review the data and testimony that was provided during last month's benchmark hearing, and we will take a vote to establish the healthcare cost growth benchmark for the 2025 calendar year and at an agreed upon level. To close out the meeting, our executive director, David Seltz, will share a number of agency updates in his executive director's report. So let's turn to the first order of business, which is to review and vote on the minutes from our last board meeting, which was on January 25th, 2024. And I'll turn over to our colleague, Colleen Elstermeyer, to conduct the vote.
Thank you, Madam Chair. Good afternoon, everyone. Are there any amendments to the minutes of January 25th? Seeing none, I would ask for a motion.
So moved.
And a second.
Second.
And we'll move to a roll call vote, starting with Chair DeVoe.
Aye.
Vice Chair Cohen.
Aye.
Commissioner Blakeney. Barbara voted aye. Thank you so much. Commissioner Castiel.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Mastrogiovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Kwasnick.
Aye.
Thank you very much. Back to you, Madam Chair.
Thank you. Our second item on the agenda today is to vote to extend the term of our vice chair position. You may remember that under statute, our vice chair is appointed by a majority vote of the board in successive one-year terms and helps guide the HPC's policymaking and programs and offer support to the chair. I can add the word significant support to the chair. And Commissioner Cohen has been serving as the vice chair of the HPC board since September 2019. He has indicated his openness to agree to serve again in the coming year. And given his success in this role and his leadership, I'd like to nominate him to be reappointed as vice chair. Any comments or questions by commissioners before we move to a vote? Thank you. And let me turn again to Colleen to take us through the vote.
Great. We'll consider that the motion on the reappointment of Martin Cohen as vice chair. And do we have a second on the motion?
Second.
Okay, great. Thank you so much. All right. By roll call vote, Chair DeVoe.
Aye.
Vice Chair Cohen, I'll ask you to abstain.
I will.
Moving to Commissioner Blakeney.
Aye.
Commissioner Castiel.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Mastrogiovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Kwasnick.
Aye.
Thank you very much. You are hereby reappointed. Congratulations.
Thank you, Commissioner Cohen, for being willing to serve again this year as vice chair. We'll now take the vote to enter a confidential executive session. And to remind the public, we will resume our public meeting agenda in approximately an hour. We'll rejoin around 1 o'clock. Can I call for a motion to move into executive session?
So moved.
Second.
Unfortunately, we do have to take another roll call vote. So I'll start with you, Madam Chair.
Aye.
Vice Chair Cohen. Aye. Commissioner Blakeney.
Aye.
Commissioner Castillo.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Master Giovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Kwasnick.
Aye.
Thank you very much.
Thank you. We'll now go into executive session. Are we back on?
Just waiting for confirmation.
We're live. Thank you, and welcome back to the public portion of our agenda. Thank you for sticking with us on that. I'll now turn to David South, who will provide an overview of the topics for our discussion.
Great. Good afternoon, everyone, commissioners, members of the public. Thank you for your patience as we completed that executive session. I will just note again that the purpose of the executive session was to discuss entities confidentially referred to the HPC for consideration of a performance improvement plan. This is part of our annual review process, and we hold these executive sessions under the law where the names and identities of the referred entities is confidential. And so that was the purpose for our executive session today. We are going to continue on this exact same topic for our first agenda item, because we are now going to report out to the public the results of this annual process by which we review entities. Kara Vidal will first walk through just briefly how this process works and our results from this year's rigorous and robust review.
Great. Thank you so much, David. Good afternoon, commissioners. On the next slide, we have just a brief overview here for you. As you know, commissioners, performance improvement plans are the key mechanism that the Commonwealth has to hold individual payers and providers accountable for their spending relative to the healthcare cost growth benchmark. And through this process, we conduct a really comprehensive and robust review of spending trends in the state for these individual entities. We try to identify spending drivers. We look for exacerbating and mitigating factors and context that influences the decision as to whether or not a PIP is warranted. When the board determines that a PIP is warranted, the PIP process offers an opportunity for the HPC to engage collaboratively with an entity to develop a plan that can address those drivers and for us to mutually monitor outcomes. Next slide, please. So as David said, we were concluding the 2023 process. We were at step 5 here. The board will actually take step 1 prospectively later in this meeting, setting the benchmark for the future calendar year. And then we were also sort of retrospectively completing steps 3, 4, and 5. So in step 3, CHIA will refer entities to the HPC based on their health status adjusted total medical expense growth. The HPC will then conduct that rigorous review that I just described, and the board will decide whether or not PIP is warranted in step 5. Next slide, please. Thank you. One point I do just want to make here, as I said on the previous slide, CHIA's referral is based on a very specific trigger. It's growth in a single year in that health status adjusted TME measure, and CHIA applies that contract by contract. Conversely, our review is designed by statute to be very wide-ranging. The first factor here that we are charged with looking at is spending, and so that is where we always start our review. But we are asked through this process to look broadly at pricing, at utilization, at population served and payer mix, size, market share, financial condition, strategies to address cost growth, factors outside of the entity's control. And we also don't have to limit our look to a single year. We aim to look over time as well, so that we can identify patterns and provide additional context. Next slide, please. Okay, so turning to the 2023 PIPS review cycle. Entities that were referred by CHIA this year were referred based on their growth from 2020 to 2021. Obviously, 2 years that were highly impacted by the COVID-19 pandemic. So as you recall, or if you were paying close attention on my first slide here where we had the full chart for the state, spending dropped in 2020 by 2.3%. And then as demand for care rebounded in 2021, spending similarly rebounded. And we saw total healthcare expenditure growth of 9% in 2021, the highest it's been since we started measuring against the benchmark. So what we wanted to do was adjust our process slightly. So typically what we do in our full analytic lift that we undertake for every referred entity is our starting point is always growth in the performance year. And we did that this year. We looked at 2020 to 2021 trends, but recognizing the disruption to the market and these factors influencing spending statewide, we also decided to look on an annualized basis from 2019 to 2021. So we looked at spending levels in 19, we looked at spending levels in 21, and then we calculated what the spending would have been if growth was even between those 2 years, rather than having the dip and spike that we actually saw. When you look with those annualized per member per month trends statewide, you see that growth was 3.2%, so much closer to the 3.1% benchmark that was in effect in those years. However, when you look by market segment, you see some differences. Mass health per member per month spending on an annualized basis was negative. Medicare spending was at 2.4% below the benchmark. Commercial PMPM spending on an annualized basis was 6.6%. So that's as if there had been spending of 6.6% growth in 2020 and 2021. So we did focus careful attention on the commercial market in our review. Next slide, please. We also wanted to be very cognizant of the factors that were influencing spending during this time period. We've already talked about how utilization and therefore spending trends were decreasing and increasing in an unusual way. We also wanted to account for the fact that there was utilization and spending that occurred in 2021 that couldn't have occurred in our 2019 baseline period. I'm talking specifically about COVID testing and COVID vaccine administration. Those services couldn't be in our baseline because they didn't exist. We used data from our sister agency, CHIA, to estimate that about 1 percentage point of that 19 to 21 annual growth was due to COVID testing and vaccine administration. So in other words, if you were looking at that 6.6% growth, it would have been 5.6% absent this spending, which, of course, was good, necessary, important spending. Then we also wanted to consider cost pressures that were unusual at this time period. So, of course, considering the fact that inflation was high in Massachusetts and nationally in 2021 and continuing on after that year. We also know that there were workforce shortages that were putting extreme pressure on providers as well. As does the fact that utilization had dipped in 2020. That's also a pressure on providers' revenue. We also were aware of the fact that providers may have sought higher than average commercial rate increases during this time period to try to offset some of those pressures. Next slide, please. So just to play out the timeline of how we conducted our review, we received the list of referred entities from CHIA last spring. We did our full analytic look at all referred entities as we do each year and shared those results with the board last July. Commissioners then helped us narrow that list to a smaller list of entities where we had additional question or concern. We worked with those entities confidentially in the summer and the fall to get additional data and information. which we brought back to the board again in confidential executive session in December and January of this year. Based on what we learned, the board did decide to advance some entities to the final stage of PIP's review. That triggered the opportunity for additional data and information sharing, as well as conversations between our leadership and the entity's leadership, which we then brought back to the executive session that just took place earlier today, based on a review of the information that we received and what we learned during this process, as well as the careful consideration of contextualizing factors at the time. The board voted not to require a PIP based on the 2023 PIPs review cycle. Next slide, please. So while that cycle has concluded, just did want to add in here that doesn't mean that our consideration of this time period has necessarily concluded. In fact, we have language that we send to every entity when we close review saying, though the board did not require a PIP based on spending growth in this year, we can and do consider all available information in our future evaluations of entities. And so we'll, consistent with that language and process, expect to review this data from this period as part of historical trends in future cycles. The next of which we expect to commence relatively shortly. We expect to get the 2024 list from CHIA, which will be based on 2021 to 2022 growth very shortly.
Thank you so much, Director Vidal. And I want to add to your comments around this year's process by saying, I'm often asked in a year where we vote not to issue a PIP, since the rest of the process is entirely confidential. I'm often asked what happens in those years where there is no public issuance of a PIP. And I want to comment on the very rigorous process that we undergo as a board. On the slide, it shows there are several months between when the staff has completed the review and the fact set and the data points, and then the back and forth that occurs with the providers and plans that are referred to the HPC and that comes out of the staff's analysis as requiring, further action and consultation. And that process is very rigorous and, in my view, has tremendous value and is constructive even in those years where we don't require a PIP that does become public. So I want to thank the team and the board for the time and the diligence that we've spent over the last few months and the learnings that we've then shared and focused on with certain providers and plans that have been referred to us. Any other comments, Director Vidal or Executive Director Seltz or any commissioners before we move to the next agenda item? Any comments? So if not, let's turn to the discussion of the performance improvement plan for Mass General Brigham.
Yes, thank you. Just a quick process update for you here. Just a few slides ago, I showed you a roadmap that made it look as though the decision to require a PIP was the end of the road. Here you can see it's really just the beginning. When the board votes to require a PIP, that then sets off an 18-month process during which an entity is developing performance improvement plan, implementing a plan, reporting on that plan, and then after implementation ends, evaluating the outcome of the plan. So we are actually in step 9 here on this slide with the Mass General Brigham Performance Improvement Plan. And on the next slide, I've got just a quick update for you on some of those details. So the implementation period concluded on March 31st, 2024, so just a few weeks ago. The PIP was initiated October 1st of 2022, ran through calendar year 2023, and then we had this quarter of 2024. So it was 18 months total. During that time, MGB implemented 10 cost containment strategies with a goal of saving $176 million over the total 18 months. During that period, we met quarterly with Mass General Brigham. They provided us with qualitative and quantitative reports on their progress. Their most recent report to us does indicate that they expect to meet the $176 million target. We now move into the evaluation stage of the performance improvement plan, during which both the HPC and MGB will be conducting evaluations of the success of the PIP. Once those are complete, the board will have to vote to determine whether MGB's PIP was successful based on a set of regulatory factors. Now, these are factors that we have been looking at and evaluating over the course of the PIP with MGB, and those include things such as whether MGB fully implemented the strategies that they defined in their PIP and whether they addressed concerns about their costs. Certainly, the sustainability of any actions is something that is highlighted in our regulation and was highlighted early in the PIP development process as being of particular importance to the HPC, as well as the impact of any events outside of MGB's control and any other relevant factors that the board identifies. So we do expect to be conducting that evaluation and bringing findings to you later this year. I'm happy to answer any questions I can.
Thank you. Any questions? Okay, well, thank you so much. Let me turn it over to David Sells to introduce our next topic.
Thank you, Chair DeVoe. Moving on in our agenda, now we would like to give an update to the board, as we do at each board meeting, on recent notices of material changes filed with the HPC and otherwise reviewed by the HPC. This is one of our standard agenda items, as I said. Today, I will mention that we will be discussing for the first time the filing with the HPC on a proposed transaction between Steward Healthcare and Optum Care. This is a significant proposed change involving two large medical providers, both in Massachusetts and nationally. And so we'll be able to share today some of the initial information filed with us, but want to note at the outset that we are very much at the very beginning stages of analyzing and reviewing that particular transaction. But to walk us through all of the transactions and notices we've received and our ongoing market reviews, I'll turn it over to Kate Scarborough-Mills.
Great. Thank you, David, and good afternoon, commissioners. So as you know, this slide shows a summary of the notices we've received to date. So since 2013, the HPC has received notice of 168 different provider transactions. Of these transactions involving the formation of contracting entities continues to be the most frequent. And on the next slide, please. This second slide captures the number of each type of transaction involving a for-profit entity. So in our last meeting, commissioners had expressed an interest in seeing a breakdown of notices based on whether for-profit entities were involved. And so this is one look at that question by category. So in general, this count reflects where any party to a transaction is a for-profit. So that could be that it is two for-profits coming together, affiliating with no change to profit status. It is also a situation where a new affiliation is being developed between a nonprofit and a for-profit. And it's important to note that many of our physician groups in the state are private practices that are for-profit. So that obviously makes some of these numbers quite high, as any transactions that those groups are involved in would be counted in this, as well as obviously we do have some integrated healthcare systems like the Steward system that are also for-profit. So anything involving Steward is in this count. But of course, this does mean that over half of the market changes that we have reviewed to date do involve a for-profit entity. On the next slide, you see that since our last board meeting in January, we have elected not to proceed to a cost of market impact review on the following transactions. So first, the proposed acquisition of Amedisys, which is a for-profit home health, palliative care, and hospice company that operates approximately 19 locations in Massachusetts by United Health Group. This was the second recent United acquisition of a large national post-acute care services organization that does include some providers in Massachusetts. But we note that in our analysis, that market does still continue to have relatively low market concentration, and United's share, even after this acquisition, would continue to be lower than that of MGB. And additionally, most of the revenue in that space comes from Medicare fee-for-service business, meaning that the potential of an acquisition to impact prices or market leverage is somewhat reduced. For these reasons, the HPC didn't find that the transaction was likely to substantially increase healthcare spending or impact the competitive market in Massachusetts. But I do want to note that our review is specific to Massachusetts, the market here, and the impact here. This transaction remains under review by federal and state authorities in other locations. For example, it's been publicly reported that the Department of Justice may be weighing antitrust action, and the Oregon Health Authority began a comprehensive review, their equivalent of a CMIR, on March 14th. Second, the proposed acquisition of certain outreach laboratory assets of Bay State Medical Center by the Laboratory Corporation of America, or LabCorp, as well as LabCorp's proposed establishment and operation of a clinical laboratory in Holyoke. In our preliminary examination, we found that LabCorp has a sizable and growing market share in Massachusetts, both through this transaction and through its recent acquisition of the outreach laboratory business of Tufts Medicine, which we had also reviewed. However, other laboratory service providers, including Quest, MGB, and BILH, remain key competitors. LabCorp's prices are also lower than those of many of its competitors, and lower than those of Bay State for the same services. However, we do expect to closely monitor LabCorp's pricing and other market behavior in light of its continued growth in Massachusetts. And we did not review any evidence indicating that the transaction would be likely to negatively impact access or quality of care. Third, a proposed joint venture between Atrius and Shields to own and operate a clinic providing PET-CT services in the Dedham area. And in that preliminary examination, we found limited potential for impacts on spending and market functioning, since the majority of patients receiving outpatient PET-CT services are again covered by Medicare, limiting potential spending impacts from changes in pricing. And additionally, Shields has lower commercial prices for PET-CT services with some payers than the current hospital-based referral sites for Atrius patients. Again, we did not review evidence indicating that the transaction is likely to negatively impact access to or quality of care. And fourth, a proposed joint venture between Shields and UMass Harrington to manage and integrate MRI services at Harrington's hospital campus in Southbridge and at an off-campus location in Charlton. And in that preliminary examination, we found that Harrington's commercial prices for MRI services are higher than those of some of the other providers in its service area, meaning that if the transaction resulted in increased scans at Harrington, that could result in some increased commercial spending, but that increase would be likely to be relatively small given the utilization numbers that we're likely talking about here. And there's also some potential for increased access and reduced wait time for those services. Again, we did not review any evidence indicating that the transaction is likely to negatively impact quality. On the next slide, you'll see that we are currently reviewing two material change notices that were already pending at the last board meeting and are still pending as MCNs, as we're still awaiting the filing of a few final pieces of information with us before those notices are complete. First, the proposed joint venture between Greater Springfield Surgery Center and Mercy Medical Center, through which a new physician-owned company would share ownership of the surgery center with Mercy. And second, of course, the proposed transaction between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty physicians at Beth Israel to establish a new cancer hospital in Boston, which the board did vote in January to move to a full CMIR review once that notice is complete with us. In addition, since our last board meeting, we've also received notice of some other transactions. First, the proposed acquisition of Milford Regional Medical Center by UMass Memorial Healthcare. On the next slide, a proposed contracting affiliation between the Pediatric Associates of Greater Salem, which is currently part of the Steward Contracting Network, and the Affiliated Pediatrics Practices, which is part of the Mass General Brigham Contracting Network. Next, a proposed joint venture between the BMC Health System and Telica Imaging to establish and operate a clinic providing MRI and CT services at 3 sites, as well as the proposed acquisition of New England Neurological Associates, many of the physicians of which are currently reported to our Registration of Provider Organizations program as contracting through the Steward Network, which is proposed to be acquired by LGH Medical Group, which is affiliated with Lowell General Hospital. And then finally, on this next slide, we've of course received notice of the proposed sale of Stewardship Health, a subsidiary of Steward Healthcare Network, to Optum Care, a subsidiary of United Health Group. And we wanted to give a bit more information about that transaction, even though, as David noted, we are still very early in our review process and the notices to us are not yet complete. So we're not yet in our 30-day review even. But to give some background on that transaction, Stewardship Health, which is the entity proposed to be acquired, is the parent of Stewardship Health Medical Group, which employs primary care providers and other clinicians across 9 states, including Massachusetts, and Steward Healthcare Network, a contracting organization that negotiates payer contracts on behalf of the providers in the Steward system. It does not include the Steward hospitals. Optum Care currently has 2 Massachusetts physician practices in Massachusetts, Atrius Health and Reliant Medical Group, as well as a chain of urgent care centers called MedExpress with 9 locations in Massachusetts. The parties have indicated that they've also submitted a Hart-Scott-Rodino filing to federal antitrust agencies, the FTC and the DOJ. And as part of our review, we are working to understand exactly which of Steward's physicians, both their employed and affiliated physicians, would be involved in the transaction, and what that relationship would be between the physicians if they are acquired and Steward's hospitals, which are not proposed to be part of the transaction going forward. However, we did want to give you some information based on what we know from public sources. So based on information that's reported into our Registration of Provider Organizations, RPO, Steward is currently the 3rd largest physician organization, or physician contracting network, I should say, in Massachusetts, behind Mass General Brigham and Beth Israel Lahey Health, with approximately 2,950 physicians. And Optum Care's network in Massachusetts, which includes Atrius, Reliant, and MedExpress, has approximately 975 combined physicians in Massachusetts. So for comparison, MGB has approximately 7,600 physicians. BILH has approximately 4,500 physicians. On the next slide, we have a map showing the practice locations for Steward, Atrius, and Reliant physicians. So you see Atrius here in purple, Reliant is kind of the more magenta, and Steward is the more aqua color. And Steward and Atrius, as you see, both operate in Eastern Massachusetts. Reliant physicians, however, are primarily in Central Massachusetts. Again, though, I want to note that this is based on what's reported publicly to the Massachusetts RPO program. We do not necessarily know that these are exactly the physicians that would be involved in the transaction. And these next few slides are just a quick reminder of the MCN and CMIR process, which applies to all of the transactions we discussed. But important to note that with regard to Steward Optum, we are not even quite yet on this timeline. The notices have been submitted, but we are still waiting for some key material. Just as a reminder, the initial review of a completed material change notice takes 30 days from that time that the notice is complete, which includes the notice and all supporting materials. And if the HPC then determines that a transaction is likely to have a significant impact on costs or market functioning in Massachusetts, we can elect to conduct a more comprehensive cost and market impact review, or CMIR, which is a process that takes approximately 6 months. On the next slide, as noted, for transactions anticipated to have a significant impact on the Commonwealth's ability to meet the healthcare cost growth benchmark or on the competitive market, the HPC has this ability to conduct a cost of market impact review. The cost of market impact review is a comprehensive review of the providers and the proposed transaction that looks at many different factors, which are outlined on the next slide, and is designed to provide public transparency into potentially important transactions. The outputs from the HPC include a public preliminary report, which the parties have the opportunity to respond to, and a detailed public final report that can be referred to the Attorney General's office or other agencies as appropriate. Providers then must wait 30 days after a final report is released before they can close a transaction. And of course, important to note that CMIRs are separate from other review processes like the determination of need reviews conducted by the Department of Public Health, and they are separate from antitrust reviews that are conducted by state and federal agencies. But our final reports can be used as an input into those other oversight processes. And finally, on the next slide, you see the factors laid out in the statute for evaluating cost of market impacts. We evaluate these both in the material change notice review process and then in more depth and detail in a cost of market impact review. And as you see here, we look rigorously across a number of factors relating to cost and market share, quality, and access. And importantly, one statutory factor is other factors in the public interest, which provides us some flexibility to tailor our review to the specific facts of a given transaction. And here I really did want to pause. Obviously, we are at the earliest stages of the review of the proposed Optum stewardship transaction, but I'd like to open it up for commissioner discussion and feedback if there are particular items you'd like to raise at this point and make sure that we include as part of that, or any of the other reviews that we have underway at this time.
Thank you. Yes, Commissioner Blakeney?
Thank you. I'm sure my colleagues on the commission are loaded with questions. And I guess a couple from me, larger questions, involve looking at Optum and understanding their relationship with the existing hospitals that the current steward physicians practice in. Part of the question is what happens to those hospitals? What happens to those providers? Do they leave those hospitals? Do they go someplace else? What happens? The overarching question is what happens to the health of the hospitals that the steward physician practices are practicing in, and what challenge does that create? I think it's a huge question. It influences the opportunity of those hospitals to provide care in their communities, and it has a huge impact. That's one level of question. I think additional questions would have to do with what is the intent of Stewart with the income from the sale of these practices to providing much needed support to the hospitals that they currently own versus how much of that money heads to Dallas and heads to corporate. And what, if any responsibilities or opportunities does our existing structure here in Massachusetts have to protect both the hospitals and the providers of that care? So my questions are at this point larger, big context questions. I think all of us have dozens and dozens of questions that get into big issues and small issues. I think the underpinning piece is what happens to patients and what happens to the small community hospitals out there in terms of their ability to stay viable and to provide care. The impact of this just is mind-bogglingly complex and potentially harmful. So I look forward, Kate, to all the work you and your whole team are going to do to help us get these answers. So thank you.
Thank you. Commissioner Cutler?
I think I really want to echo what Barbara said, which is that there are a lot of different considerations here. Some related to antitrust and pricing issues, some related to health issues in the Commonwealth. And it's going to be very tricky because it's not just this single transaction, but it's going to have implications for the hospitals and for other medical care providers in the community. So it's both going to be difficult to do because of the filling out the if you will, the what it is, and also difficult to do because of the scope of the implications for patients and for spending. And so we're going to have to take our time and make sure that we're getting all of that right. And I think that's our responsibility to do. So we'll wind up doing that. But this is going to be much harder, I think, than many of the transactions that we've had, and even those have had very, very significant, tentacles that we had to follow up. So I'm just sort of, people should just be aware that it's going to be a very complicated analysis.
Thank you. Commissioner Foley?
Yeah, I totally agree with all the comments made prior to me. The one question I have is, I think I saw the slide earlier say that this is not considered a complete filing, so that the 30-day time period is not even started yet. So I guess my question is that what is missing, and is there a timeline to receive it? And when do we believe that 30-day clock will start?
So to respond quickly to that question, the materials being requested are confidential. So unfortunately, I can't publicly disclose those things that are still pending. Certainly, we know that this is something that is a priority for folks to move quickly on. We have been working closely with the parties to try to get the information we need to conduct this review.
Thank you. Well, there'll be notification of when that application is complete, to when the 30-day clock will start.
I think we can certainly plan to let folks know when we are officially on the clock.
Thank you.
Commissioner Cohen?
Yeah, I think Commissioner Blakeney summarized the major issues quite well. I would just sort of also add, is there anything that we may have learned from both the Reliant and the Atria sale that would help us understand what the potential impact of this sale could mean? We now have a few years under our belt with those transactions, so I would just add that to the agenda as well.
Good point. Yeah, I also
Certainly
want
be
to
looking at that.
underscore the points that are being made by my fellow commissioners. When I think about the history of Steward and forming as a system, the vision was to create more value to patients and to cost in the Commonwealth by bringing together and integrating physicians and hospitals in the best interest of patients. Now that the proposal is to sever that, I think, as others have said, it is impossible to understand the impact of the proposed physician transaction without understanding what that means for the hospitals and, of course, for the patients. So appreciate everyone teasing out that the set of implications from that. Commissioner McGregor?
Yes. I'd just like to highlight the importance of understanding the implications on the workforce. So not only the physicians involved, but also the other clinicians that aren't physicians. So nurse practitioners and more. What are the impacts of this transaction on the availability of these clinicians across the various service areas? And then in terms of the physicians themselves, how will this transaction impact the distribution of specialists that are available, especially those specialists that are of critical need? I'm thinking of OBGYNs and more. So just want to make sure that that's also included here.
Thank you.
Other comments or questions for the team? So as we've noted, much more to come. We will make everyone aware when we've received all the materials that we need to begin the 30-day process of preliminary review. And any other comments from the team?
No additional comments at this time, Chair DeVoe. Thank you.
Okay, good. Well, thank you so much. The importance of this cycle is very well understood, the importance of this filing, and we will look forward to next steps. So let's move to the next item on our agenda, which is to focus on potential policy solutions regarding private equity. And Director Seltz, did you want to introduce our speaker?
Well, quickly before we move on to that agenda, and we had one final slide in the market oversight section, just wanting to inform the board about some other recently proposed market changes that are not filed with the HPC, but are filed with the Department of Public Health. And we like to inform the board of these filings as well. So, Kate, can you provide a quick summary?
Right. Yes. Thank you everyone for the feedback on the ongoing review for Steward Optum. We will certainly take all of your comments under advisement as we continue. And just as David said, wanted to just give you a brief overview of two recent filings with our colleagues at the Department of Public Health. So first, Mass General Brigham has requested to add 94 beds at Mass General Hospital. So as you may recall, this request was part of an original proposal to expand MGH by adding a clinical tower, which the HPC commented on in January 2022 and was approved by DPH except for those 94 beds. However, the approval at that time left open an opportunity to refile for the beds, and MGH has now done that. And so just as a reminder of kind of the details of how this works, so the MGH tower, which won't be open until at least 2027, is expected to house approximately 388 private inpatient beds, as well as some oncology and cardiac procedure spaces, some other equipment. And many older semi-private beds at MGH are expected to be closed once that tower is complete. Even without additional 94 beds, the tower is expected to net effectively 64 operational new beds. And so this amendment is really for MGB to seek permission to add 94 beds to its license, which are beds that it's essentially already using in its current buildings, but it would otherwise have to close when the tower opens in 2027. And so MGH is instead proposing to renovate the current building and keep those beds operational. As you may recall, we detailed in our comment in 2022 that due to the higher prices at MGH relative to other providers, increasing beds at MGH absent some restriction on pricing would likely increase annual commercial spending by between 23.7 million and 40.6 million. And so just wanted to note that the proposal that has been filed as an amendment is substantially unchanged from that previous filing. So we do still expect a commercial spending impact in that range, and that analysis in our previous comment is available to our colleagues at DPH. Also, as noted at the bottom of this slide, Cape Cod has also requested permission to build out 32 new permanent inpatient beds in shell space that was approved under a prior DON that would replace 14 to 19 temporary beds that Cape Cod has been staffing above its licensed capacity. And then finally, I just wanted to note that as you all know, many providers have been identifying capacity challenges in recent months. So we did want to keep you updated on these proposals, which providers have been putting forth as potential solutions. But as we've highlighted in the benchmark hearing and at our most recent advisory council meeting, the recent capacity challenges are driven by a somewhat complex set of challenges beyond a lack of inpatient capacity. We're seeing patients stuck in ED departments because of lack of primary care, lack of post-acute and home health capacity, which are driven by workforce challenges, And so we really look forward to engaging with providers as well as our agency partners as we all seek to address those challenges in a collaborative way, while minimizing further pressure on healthcare costs in the state. And that's what I have for you in terms of market updates. Back to you, David.
Thank you, Kate. And on this topic of capacity within our healthcare system, something that is certainly top of mind for many. As I go and talk to different organizations, those capacity challenges from the emergency department in the inpatient space to post-acute care are complex. And we think it's worthwhile to spend more time together as a commission and a board wrestling with some of those challenges. And so we're planning to set aside a good chunk of our committee meetings in May to bring forward to this commission a presentation on needs and supply within Massachusetts. So a little bit of a preview on that topic, and look forward to having you all be able to participate in that conversation. We're now going to switch gears to our next agenda item, which is going to be focusing on the rising and increasing role and influence of private equity in healthcare. This topic has garnered considerable attention in the recent months, in no small part due to the ongoing financial situation of Steward Healthcare and its history with private equity, but really reflective of broader attention and concern about these roles, these financing and corporate structures in healthcare generally. We were able to participate as an invited guest to the Joint Committee on Healthcare Financing, who held a special hearing a few weeks ago focusing on the effects of private equity ownership and investment in healthcare. I was pleased to be able to represent the HPC at this special hearing, along with my colleagues from the Executive Office of Health and Human Services. The committee also invited a number of esteemed experts and researchers and guests to provide testimony, again, on the effects of private equity ownership in healthcare. I found this special hearing to be a really robust conversation on these effects and what we are learning about these effects over time. And so wanted to bring to this board a little bit of the presentation that I gave to the Joint Committee, as well as reflect back some of the summary points that the other witnesses provided to the Joint Committee. I want to especially commend Senator Friedman and Representative John Lawn for organizing this great hearing. You can see here on this first slide a quote from Senator Friedman as she was kicking off this hearing, recognizing the imperative that we must better understand the role of private equity in healthcare delivery, and recognizing differences in models where there is a business model for short-term investment for enormous financial return versus a model which is around providing high-quality healthcare. Understanding these financial models and their potential impact is something that we have also dove into at the HPC, and we have dedicated some research to understanding how these investments are structured. In what sectors are we seeing more of private equity investment in Massachusetts over time? And also want to share and open a dialogue with this board around what our potential policy responses may be to this. Clearly, legislators and the public, and I would also mention that Senator Warren and Senator Markey also held a hearing recently about private equity. It's clear that the public is right to demand answers to the questions on the role of private equity financing and incentives in Massachusetts. And I would add that there is a need for policy action, as we'll discuss later, to ensure that all organizations in our healthcare system are transparently operating in good faith by a commonly accepted set of rules. The need for urgent policy action could not be greater. First, before we turn to those policy options, I'm going to turn it over to Yua, who has led the HPC's research in this area, to provide a brief overview of what we mean by private equity, what some of our concerns are, and the growing trends in Massachusetts. So I'll turn it over to you.
Great. Thank you, Director Saltz, and good afternoon, Commissioners. I have presented on some of this materials back in December when we were together for the board meeting. So I'll go through these materials relatively quickly, but stop me if you have any questions. So we know from the national literature that private equity investments in healthcare have been growing and accelerating nationwide. This is true in the physician market, but this is also true in many other areas of healthcare. Increasingly, private equity and other for-profit firms use complicated corporate structures with multiple layers of subsidiaries in these transactions, including the use of management service organizations, MSOs. And these complicated structures really make it challenging for policymakers and the public to track and monitor the changes in ownership and operations of our healthcare providers. And of course, all of this is happening against the backdrop of ongoing consolidation in the healthcare system overall. So on the next slide, I will provide a brief refresher of private equity and why it is unique and different from other forms of healthcare investments. So private equity firms form funds by pooling investments from institutional investors. These are pension funds, university endowments, wealth sovereign funds, etc. And the private equity firms themselves also put in some money in the funds. And the firms use these funds to make acquisitions. And the goal is to increase the value of the companies that they buy and quickly turn them around and, within 3 to 7 years, sell them for a profit. So because they operate on such a short timeline, private equity firms pursue some strategies that are unique and introduce instability to the healthcare market. So some of the examples of strategies that are unique to private equity are leverage buyouts. That refers to when a private equity firm acquires a company using debt and then using the company it acquires as collateral. So all of the burden and the liability goes on the company that acquires as opposed to the private equity owners themselves. There's also the sale leaseback of real estate, I think, which many of us are sort of learning for the first time, partly as a result of the Stewart situation as well. This is when the private equity owner of a healthcare provider with a physical plant, so it might be a nursing home or a hospital, sell the real estate of the healthcare provider because real estate often is highly valuable and even more valuable than the operation of the healthcare services themselves. So they sell the real estate and then to a real estate investment trust, and then the private equity owners use the proceeds from the sale to essentially pay themselves dividend, but then the healthcare providers are burdened with a rent on properties that they previously owned. So those are just two examples, but of course there are other strategies that private equity firms use. Generally speaking, private equity firms operate under the regulatory radar. They are not subject to federal financial disclosure requirements. So there's very little transparency into the firms themselves and their activities. And lastly, private equity investors are lay investors, right? They often do not have healthcare expertise, and they're not necessarily bound to the institutional or ethical norms that are expected in the healthcare profession. And again, these investors are buying to sell. They have no long-term interest in staying in the business. And we have a growing body of research that suggests that private equity ownership can affect spending, quality, and access. And a lot of that evidence was described in detail by our guest speaker, Dr. Song, in the December board meeting, so I won't go into that here. So then on the next slide, I think we'll go into our research. This is the analysis that I presented in December as well, but we have since then updated the analysis with one additional year of data. So the results I will present will take you through the end of 2023. Last time we stopped at 2022. So we at the HPC wanted to understand the extent to which private equity has invested in Massachusetts healthcare providers. So to be able to do this, and again, I mentioned there's layers of corporate structures and there's very little transparency. So to be able to do this, we cobbled together 3 data sources to create a data set of provider mergers and acquisitions. One of the data source is our own material change notice filings, but we also purchased 2 proprietary data sets that track healthcare transactions. And I have a list of detailed exclusion criteria here, but the idea is that we wanted to understand, transactions of healthcare providers that largely operate within the insurance system and directly provide care to patients. I think one important method I wanted to highlight is just that providers need to be located in Massachusetts. The acquired providers need to be located in Massachusetts to be included in our analysis, but the buyer or the private equity firm could be anywhere in the world. That doesn't matter. It's just the acquired provider needs to be in Massachusetts to be part of the study. So on the next slide, we have the total number. Here we show the total number of provider transactions identified in our analysis. We have 182 transactions from 2013 to 2023. And you'll see the blue portion of the bars indicate transactions that involved private equity. So of the 182 transactions, 85 or 47% involved private equity firms. Of these, 74 were private equity acquisitions, 3 were private equity exits, and 8 were acquisitions and exits, meaning a private equity firm sold to another private equity firm. And right off the bat, you'll see that in the home health and hospice sector and the behavioral health sector, not only were there a large number of transactions overall, these sectors are also where private equity has been very active. We also saw a lot of private equity investments in certain specialty providers, such as in dentistry, physical therapy. And I think the common thread here is that these sectors are all relatively fragmented. So the private equity investors may see this as an opportunity to consolidate. And I remember there was a question from Commissioner Foley back in December about the home health and hospice sector, kind of just clarifying the distinction between home health and hospice. So I just want to add that here. Of the 40 transactions, the vast majority were home health providers, 36 were home health providers, and only 4 were hospice. 4 transactions were hospice providers. So then we can move on to the next slide. This slide shows the number of transactions over time, and you can see that the proportion that's blue has been going up and up over time. So from 2013 to 2016, private equity was involved in 25% of the transactions. And in the last 3 years, from 2021 to 2023, that's gone up significantly. We now have 63% of the transactions involved private equity. And then next slide is this bubble chart where we try to give you a sense of just the patterns in which private equity firms make acquisitions. So here, each bubble represents a private equity firm or distinct group of firm that made acquisitions in a given sector, and the size of the bubble is proportional to the number of acquisitions that were made. So as an example, if you look at the biggest bubble in this chart, the one above the one at the bottom of the dental row, that means a private equity firm made 8 transactions in the dental space. So I think the main takeaway from this slide is that many private equity transactions in Massachusetts have been one-offs, but we do see cases where an individual firm is making multiple acquisitions in the same sector. And then I think the last data slide I have on the next one just gives you some additional detail on private equity transactions in select sectors. I think we've highlighted a lot of these before. Again, I'll highlight that within the behavioral health sector, within the 23 transactions there, 10 of them were acquisitions of pediatric behavioral and developmental disorder providers. Again, this is consistent with a national trend that private equity firms have really been going on a buying spree of autism providers in the past couple of years. So that was a quick summary of our data analysis. I will move on and give you some high-level takeaways from the Joint Committee on Healthcare Financing hearing that Director Saltz mentioned. Again, as he said, it was a 4 or 5 hour, it was a 5-hour hearing with lots of rich discussions. So I won't provide a summary of all the panels, but here are some highlights. So we had a panel with 3 researchers who provided research on the impact of private equity on healthcare, and they covered evidence from hospitals, nursing homes, hospice providers, as well as physician practices. And I think it was quite clear from their presentation that the evidence on cost is most consistent, right? Research consistently finds that private equity ownership increases cost and spending. The evidence on quality is more mixed, but does indicate concerns with quality. And we think it's important to highlight that we have this quote here, the bottom quote here, that at the moment, rightfully so, private equity is receiving heightened focus, as Director Saltz said, partly because of the current situation with Steward, but really private equity is just one financial actor. We have real estate investment trusts, we have hedge funds, other private investors, healthcare entities themselves are becoming investors sometimes. There's companies that offer medical credit cards, right? There's many forces in the healthcare. There are many of these financial forces in the healthcare system, and our healthcare delivery system overall is becoming more financialized. So important that we look at private equity, but there are other financial actors that we should be paying attention to as well. On the next slide, we wanted to highlight some policy levers that could potentially be used to address the impact of private equity. That was presented by legal scholar Erin Pusey-Brown. She discussed potentially strengthening state oversight authority over healthcare transactions, strengthening the corporate practice of medicine prohibition, and she also highlighted the importance of ownership transparency. I think really this is a theme that came up over and over again, that there is no centralized place where researchers and policymakers and the public can learn private equity firms and their activities. So I think on the next slide, we have a quote from her that says, "As you heard this morning from David Saltz and from all the researchers, even the state officials and researchers with the greatest access to data often find themselves using manual Google searches and expensive proprietary databases to try to get a sense of the degree of private equity penetration in the state. And for patients, there is no searchable database to know whether your doctor or your hospice or your hospital is private equity owned. And I can share that this very much reflects our experience doing this research, right? We cobbled together 3 databases and manually validated hundreds of transactions just to understand who is buying what. We read, right, press releases and news articles, and I'll just share. I remember in one instance, I had to dig through the entire YouTube channel and Instagram feed of the subsidiary of a company that was owned by private equity just to confirm an acquisition, just to confirm the acquisition of a dental practice. I mean, that's just the length we had to go through to build a really basic database of, you know, who's buying what. And we have no information on you know, how much at the time of the purchase, how much debt, for example, these providers are taking on, who is financing these deals, what are the terms, right? The public and the policymakers really have no insights into these really important details. So in summary, I just wanted to highlight that, you know, consistent with national trends, private equity investments have accelerated in Massachusetts since 2020, based on our research, both in volume and as a share of all healthcare transactions. Research indicates that private equity acquisitions often result in higher prices and are often associated with higher utilization and worse quality of care. And there are, of course, opportunities to increase transparency of private equity investments and the impact of their financial strategies on the healthcare market. I'll be happy to answer any questions, but I will at this point turn it back to Director Saltz.
Thank you, Yua. I think we'll want to pause here to see if there were questions for Yua on the HPC research and on the other research that we've reviewed. Commissioner Blakey.
Thank you, and Yua, thank you. It certainly sounds like a painstaking process of trying to collect the data, and thank you for the extra effort that you put into doing it. I think there's a tremendous amount to be alarmed about here, but I do have I've got a lot of questions. But the one question I'd like to ask is, I very much noted the issue of the 10 pediatric behavioral health practices that you described, and the fact that I think you said that the private equity companies were on a buying spree to purchase autism type programs. Understanding that private equity stays with an acquisition for a limited period of time, are we far enough into the cycle to know or be able to track what happens to those acquisitions once private equity is done with them, once they've bled them dry?
Yeah, that's a great question. I don't have a quantitative answer to that question. My guess is that it's a bit early to tell. The national research on this found that something like 85% of the acquisitions of autism providers were done by private equity investors from 2017 to 2022. So I think if they're buying within that time period, we might just be at the beginning stage of them perhaps beginning to sell off some of these providers. So I think I'm guessing that it might be a bit early to tell, but generally speaking, private equity firms exit in a couple of different ways. They might sell to a non-private equity owner, for example, to another for-profit entity. They might go public, although I think that would be less common with small providers. And then the third way that private equity exit is a secondary sale to another private equity firm if they think, right, this often happens if the secondary buyer thinks there's still more value to be extracted, right? So they kind of get sold off to another private equity owner, and that cycle kind of begins again. So that's a very general answer to your question, but I think so the autism provider, it may be too early to tell.
You know, it feels as though, from what you're saying, and again, we're early in the process, so it's hard to know, but it almost feels to me as though once an acquisition occurs, that there's very little strength left in that quote acquisition once, if ever, they're done with it. Thinking specifically about autism, thinking about the absolute crisis in pediatric mental health, it leaves me kind of despairing for our ability to provide mental health services to our children if in fact they're taking a larger and larger percentage of the services that are offered. You know, it feels strongly to me that the most important thing that can happen both in Massachusetts and the country is that we move very quickly to develop legislation and policy and oversight to stop this from happening, because it feels like cannibalism to me. And we don't have a strong enough healthcare system to sustain this. And it's not right. It's not right. So, and I know I'm on a bit of a soapbox, but I kind of can't help myself. We have to stop this, and we have to use every possible tool available to get that done. I personally look forward to the role that the commission is going to play in the assessment of this work, and I'm hoping we can get further tools along the road to strengthen our ability to measure this and to react to it. And thank you for letting me vent a little bit.
Thank you, Commissioner Blakeney. And I think I'll take over now and move on right off of that topic, which what is our policy response? How can we evolve our oversight tools to meet these challenges of today and tomorrow, where we see this accelerating trend of private equity investment in Massachusetts? We see an emerging evidence base of documented increases in costs and spending, impacts on quality, access, and on workforce, and a lack of baseline transparency about when, where, and in what type these transactions are taking place. So I want to spend the next couple slides just talking a little bit about our current market oversight and why I believe that this current market oversight needs to be updated to reflect the changing market environment in healthcare. So we've talked a lot today about our current process for receiving notices of material change and reviewing those through our market oversight process and the potential to have a cost and market impact review. The material changes notices that we receive in the past have sometimes included private equity. I've included two examples in the first bullet here of examples where we have gotten notice of transactions and have been able to understand what is being proposed, to review them, and that information is public. However, there are many transactions that in our research that you went through that were never noticed to the HPC through our MCN process. Why would that be? Well, under our current regulation and statute, there are certain thresholds and standards for what constitutes a material change. Material change includes mergers and acquisitions between healthcare providers, new joint contracting and clinical affiliations between providers, affiliations between providers and health plans, and the creation of new entities like an ACO. But there are certain financial thresholds that exist about what constitutes a material change. And additionally, for most of those affiliation types, only those transactions involving two or more providers or a provider and a payer will typically trigger an NMCN filing. So the HPC may not receive notice of transactions between a provider and, for example, an investment firm not previously in the business of healthcare. I've noted for here, again, one example where the HPC did not receive notice of the acquisition of Steward's hospital real estate by Medical Properties Trust, which were then leased back to the hospitals and MPT's concurrent acquisition of an ownership stake in Steward. Next slide, please. We also have currently a process for being able to collect robust, standardized information from all provider organizations on their corporate structure, on their governance, on their contracting affiliations, and their financial performance. We call this the HPC's Massachusetts Registration of Provider Organizations, RPO, an acronym you've heard many times already today. This is a powerful data set that allows us to be able to really understand the structure of our provider organizations and their performance. This program requires the submission of comprehensive financial statements, included audited financial statements at the system level. However, we know in the case of Steward Healthcare, they have refused to provide its audited parent financial information to HPC and CHIA and continues to engage in over 6 years of litigation to challenge the state's transparency requirements. Finally, I would note the threshold in statute for the RPO program is $25 million in commercial revenue. I believe that this was an unintended provision in the original drafting of this law, and that removing that limitation on commercial revenue and including important public revenue from Medicare and Medicaid will allow us to bring in more provider organizations that primarily rely on those public players who might not otherwise meet the $25 billion in commercial revenue. And as we just saw from Yua's presentation, it's in some of those areas that may have higher public payer mix that private equity is specifically targeting. Next slide, please. So what can we do about this? So first, we're recommending, and this was part of our cost trends report recommendations, that we do need to update and amend our HPC's material change notice process to capture a broader range of transactions, reflecting these emerging market trends, including things like substantial changes in capacity, significant investment by private equity or for-profit in an existing provider, the substantial sale of assets for an ownership share or for the other purposes of a leaseback arrangement. These simple changes will draw in transactions that right now are not subject to any scrutiny or transparency at the state level. We also would consider amending our statute to allow for participation in our other oversight and transparency functions, like the cost trends hearings, to maybe have the ability to call owners and investors in healthcare providers in Massachusetts to testify under oath, as other CEOs are required to testify under oath today. As I've mentioned, I think we recommend amending the thresholds for which organizations are required to register through the RPO program to get at a broader swath of provider organizations across the state, and to update those penalties to enforce compliance and ensure that all entities are complying and providing that information in a timely manner. Next slide. There are also complementary recommendations that we made in the cost trends hearing, specifically around how the state can evolve its ability to understand overall capacity, supply, and distribution of healthcare resources and services across the Commonwealth. This often takes the term of health planning, but we think of this really as a data-driven assessments of supply and distribution, and to understand where there are mismatches in that supply and distribution and patient identified needs. Having this understanding of a data-driven assessment of our supply will help inform our ability to evaluate transactions that come before us that seek to change or augment that supply and distribution of services to ensure that the proposals are in line with patient need. And finally, I want to suggest here an opportunity to consider going further, which is to understand that the HPC and our market oversight role is truly just a public transparency role, and we have no authority to deny, approve, or impose conditions on any of the proposed transactions that come before us, even if we have identified significant negative harms to patients in the Commonwealth. Other states are taking different approaches here. Oregon, for example, has empowered their Oregon State Health Authority to do those things, to be able to impose conditions and to have ongoing monitoring. I think there's an opportunity in the state to think about how we can augment our market oversight processes, both at the HPC, DPH, and with the Attorney General's office, and think about what it may be to have a structure that could impose potential conditions that would mitigate some of the potential harms that you talked about. Those conditions could be things around maintaining efforts on essential services or critical services, transparency requirements on an ongoing basis, compliance monitoring, the ability to maybe impose corrective action plans, conditions around quality and patient safety that we would monitor after a transaction, and perhaps even conditions around that further exit or sale of an organization. I wanted to present these ideas and options to you, the board, today. And I'll stop there because I'd really like to just pause and open it up for your thoughts on some of these recommendations that we've put forward here around enhancing oversight, accountability, and transparency, and to see if there are other additional ideas you'd like us to research as we continue to put forward our body of work on this particular topic.
I'll just start that I think that it's great. I'm sort of on the Barbara Blakeney, Commissioner Blakeney, and her comments, and I feel the exact same way. So putting some of these policies in place certainly would be great.
Commissioner Foley?
Yeah, thanks. I think these are great recommendations and clearly an important conversation. I think there's just two things that I would like to add, because I've been talking a lot about home care every time we talk about private equity investments, and you can tell that it's growing. And that in Massachusetts, we have no common set of oversight, licensure, and ownership structure. We don't have that at all. We've had a commission that met many years ago to make recommendations for action on some home care licensure oversight, to make sure that folks are meeting a standard, that we know who owns these home care agencies. If you have a 10% ownership stake, you need to report that you own that, disclosure requirements. So I think that these tools are important for us as the HPC, and there are other things that we could be doing to better understand who is owning these homes, and playing by one set of rules versus another in the home care space is just not effective. We're doing the same thing on the nursing home space. There was actually a bill passed by the House around disclosure of ownership and suitability reviews to understand who are we granting these licenses to operate in the state, what has happened in other states, understanding, like, granting a license through a stronger suitability review is to stop them from entering the market. This is when they come into the market, what we're doing. So what are those entry points? And I know this is not necessarily germane to the Health Policy Commission, but I do think federally and with our state leaders here, how we're looking at the Medicaid rules of participation, the rules of participation of Medicaid, that there's a lot of power in making some sort of federal changes around granting your ability to receive Medicaid patients. How do we use those rules of participation to limit access, or to set up escrow accounts for, if you're going to try to pull money out, we want to make sure that there's some way for us to claw some of that back in that cases. So I do think these plus additional tools that we can do at the state and federal level are critically important for entry into the market versus when they get in, what do we do? So I think it's got to be both. Thank you.
Commissioner Cutler? You're on mute.
Sorry, I thought I had pushed the unmute button, but my mistake. I wanted to think about putting the possible actions into two buckets. The first are information-based ones, like, we need to be able to get information on this, and things about CMIRs and so on, none of which are regulatory, but all of which are about being able to provide information. And then the second are things that may not necessarily be HPC specific, but are things that some states may try and do, like regulating private equity investment or putting limits on when money can be taken out, or on management fees, or on borrowing for investing in healthcare, or on sale leaseback kinds of things. Those are all tools that a state can use that are not necessarily information related, but I think it would be helpful to have those two. So one could say, look, clearly here's the information agenda, and then here's more of a regulatory agenda.
That makes a lot of sense to me, Professor Cutler, in terms of a framework for organizing. And I think our lens always kind of goes initially to kind of what we know the most about, which is the HPC's role in this market oversight. But there are certainly other agencies and regulatory processes that could also play a role, both in the Attorney General's office, in licensure, in oversight, and as well as some of the financial regulations that you're suggesting. So I think we'll cast a wider net as we're continuing to write this up.
Commissioner Cohen?
David, this is a great list. My hope is it's not too little too late. And my thinking was along with Professor Cutler's. I mean, what's regulatory, what's statutory, what's informational, and so obviously there's a lot of change that would need to happen, and it would be nice to know which of those require what kinds of actions to move this forward. I will also note that lowering the threshold would allow us to have a closer examination. The dollar threshold would allow us to have better information around behavioral health, since most of those providers are currently below that level now.
That's exactly right, and that's our assessment of that as well. And anything we do here will want to be thoughtful about where we set those thresholds, not to add unnecessary administrative burden, but there are large organizations that we currently do not have insight into. Dr. McGregor?
Yes, just wanted to underscore the need for just improved oversight of resource allocation and resource planning, especially as we experience hospital closures, the closures of maternity wards and inpatient pediatrics and other vital service lines. It's really important to have a lay of the land and the landscape of care, especially since we know these services are more likely to leave the most vulnerable communities more so than others. And especially as the kind of market activity that we're discussing now, like the increased role of for-profits and private equity, sometimes are precipitating events to closures, right? We've seen this play out across the country. And I would be remiss not to sort of add in something to a previous comment in our discussion around the stewardship Optum transaction. I mentioned that the importance of knowing sort of the distribution of OBGYNs, but also wanted to mention the importance of knowing the availability and distribution of midwives, which are critical providers in maternity care. So just wanted to add that in.
Thank you. And we'll hear from Commissioner Blakely and Master Giovanni, and then I'm going to just ask to close on this part of the discussion so we can move to the next agenda item. Commissioner Blakely?
Thank you, Madam Chair. Very quickly, I like what I'm hearing with all of the proposals in terms of regulatory and procedural processes, and I would happily support all of that. But I think there's an additional layer above that, and that layer has to do with how predatory private equity is, and why in the world would we allow a predatory process to engage in our healthcare system? I know this might be very naive. I'm not a lawyer. I'm not an economist, but it strikes me that part of the discussion needs to be, how do we keep them out of healthcare? What are they doing in healthcare? Why are they there? Why are we allowing it? So I know that's so far above the pay grade of the Health Policy Commission. I know that. And I'm not suggesting that we try to take it on, David. It's okay, relax. But I do think these are larger questions, and to the extent that we are the agency that we are, can we ask those questions? Can we make those challenges? What is a predatory practice doing in our healthcare system? That's it.
Thank you. Ron?
Thanks. From a different perspective, there's something else to consider as well. If the more regulations we have, the less valuable those businesses are, and the less interest you'll have from private equity. So now that raises another potential issue. We've seen a lot of negatives related to private equity involvement. If they started backing out, how does that impact the healthcare industry, right? I think you really got to look at regulation and the impact it has on valuation and the growth of the value of the business, because that's why they're getting in, right? In order to sell. So now, if they're no longer going to get into the business, how does that impact the industry? That's it.
Thank you. Thank you, commissioners, for all your thoughts on this. This will continue to be a topic that we will talk about again at these board meetings. On the next slide, I will just briefly share that we are planning to put together a little white paper for a publication that would summarize our research, our scan of the academic literature to date, and also include some policy considerations. So that is in progress. Expect to work with you on the final development of that paper in the weeks and months ahead. I also want to just mention some of the data sets that you had mentioned earlier didn't have certain transactions involving long-term care and senior living facilities. And we know that that is another sector that has had some private equity interest in the past. And so we're going to augment our research in that area. And then finally, just a note to say, we are working very closely with our sister agencies in the Office of Attorney General, EOHHS, DPH, as well as our legislative colleagues in the House and Senate to craft and design a policy response to the alarming trends that we have just talked about today. So look forward to talking with you more on these topics at future meetings. We have one major final agenda item, which I will move right into. This is a topic and a vote that is not new to many of you. Today, we are going to be voting on setting the healthcare cost growth benchmark for calendar year 2025. Just as a reminder in this process, the process begins every year where the administration, the Healy-Driscoll administration in this case, and the House and Senate agreed on a number for long-term economic growth in the state of Massachusetts. They agreed that that number would be 3.6%. That number is important because it becomes a benchmark for how we set the benchmark. Last month, we held a great hearing with the Joint Committee on Healthcare Financing. Thank you again to the chairs and their staff for helping us host that important event. And thank you to all of the witnesses that came and provided testimony, both in person and in writing. All of that testimony that we received is on our website, and our YouTube channel has a full video of that event. But today, we are here to vote to set the benchmark for calendar year 2025. The law prescribes that there is a default benchmark rate that is equal to that long-term economic growth rate, so 3.6%. However, the board does have the authority to modify to a different number than 3.6% by a 2/3 vote, either higher or lower than the 3.6%. If the board votes today to modify, that triggers an additional notice and potential review and oversight by the Joint Committee on Healthcare Financing. Next slide, please. This is just a visual graphic of where we are in the statutory process, that the default benchmark is at 3.6, and our authority to modify can be above or below that threshold. If today we vote to stay at the 3.6% benchmark as prescribed in law, the process will be complete for the year. Next slide. I will not present all of the figures on this slide in the interest of time, other than to just have a summary for the record of what we heard at the hearing around some of our recent spending trends and the important implications on affordability. And if I have to take a minute, I will focus on the affordability implications, where we saw in the most recent CHIA report a 26% increase in cost sharing. So these costs are being shifted on to employees and families in Massachusetts. This is resulting in many Massachusetts families not accessing the care they need due to the cost of care. And we see increases in out-of-pocket spending across the board, leading to and also contributing to disparities in health access and health outcomes. Next slide. So we did receive testimony from a number of stakeholder organizations, both in person and in writing, as I mentioned. Many organizations did not necessarily specify their recommended benchmark, but you can see here a summary where many organizations recommended not increasing above 3.6%, lower than 3.6%, maintaining 3.6%, and other organizations who called for a suspension of the benchmark. That is not something that is contemplated in our statute or law. Next slide, please. We are not alone across the country in having to make this determination of where to set an appropriate healthcare cost growth benchmark. There are many other states that have implemented very similar targets to Massachusetts. Among the states that have healthcare cost growth benchmarks, 5 of them have already established their target rate for calendar year 2025. And those rates range between 2.9% and 3.6%. Next slide. Finally, before we turn to the vote, I want to continue to recognize that even as we vote today to set the healthcare cost growth benchmark for calendar year 2025, the HPC has advanced a comprehensive set of recommendations to evolve and modernize our entire approach to monitoring healthcare cost containment growth and moderating those areas where we see spending growth is the highest, for example, in prescription drugs. I won't walk through all of these recommendations, I promise, but other than to say that these are important changes that we recommend to complement our work on enforcing the healthcare cost growth benchmark. And the next slide, I'll just highlight that we had one specific recommendation that we hope to work with the legislature on about strengthening the benchmark process and including an additional focus on affordability and health equity to complement our trends in monitoring healthcare spending. Next slide. So with that, I will turn it over to you, Chair DeVoe. I'm happy to answer any questions about this process. I know I went quickly through that, but I know we're over time. I'll turn it over to you, Deb, to lead the board discussion on this matter.
Thank you. Thanks so much. Questions for Director Seltz or comments from commissioners?
Deb, given the testimony that we heard last month, I would move that this motion to have the cost benchmark set at 3.6%.
Thank you. Other thoughts or comments?
I just want to say that I second what Marty Cohen said.
Are there any commissioners that want to speak on behalf of either raising the benchmark or lowering it from 3.6? If not, I think we're ready to move to this motion. We did hear some testimony indicating due to affordability concerns, a lowering of the benchmark. We didn't hear any recommendations to raise the benchmark. And in the current environment, I, agree with Commissioner Cohen and Castile that staying with our current benchmark is a good outlook for 2025. So with that, can we take that recommendation as the first motion, Colleen?
Yes, we will take that motion from Vice Chair Cohen and the second from Commissioner Castiel and move forward to establish the benchmark at 3.6% with the vote from you, Chair DeVoe, first.
Yes, approved, agreed.
And Vice Chair Cohen again for your vote, please.
Aye.
Commissioner Blakeney,
Aye.
Commissioner Castiel,
Aye.
Commissioner Foley,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner McGregor,
Aye.
and Commissioner Kwasnick.
Aye.
Thank you.
Thank you. That is our last vote for the meeting today, but I do want to turn to the Executive Director's report where David Seltz will give us an overview of topics that are slated for our May committee meetings and a look at upcoming work from the HPC.
Thank you, Chair DeVoe, and thank you, commissioners, for that important vote to set the benchmark for next year. I will be very brief. Just please advance to the next slide. Next slide. Just to give a preview of some really exciting topics that we're going to be talking about at the May committee meetings. As I mentioned earlier, we're going to talk about an assessment of healthcare needs and supply in Massachusetts at the MOAT meeting starting at noon. And in the care delivery meeting, we're going to provide some new research and findings around severe maternal mortality and morbidity in Massachusetts, and an opportunity that we see to address those trends through investments in remote blood pressure monitoring. So look forward to those committee meetings, commission members and members of the public. And with that, we can close today's meeting.
Sorry. Thank you so much. I really want to thank the commissioners for today's meeting and for all of the work leading up to it, and to the public and your sticking with us and your patience and bearing with us on the executive session. I do want to add huge thanks to the staff of the HPC. They're managing a workload that's exceptional in complexity and impact. And on behalf of the board, I've received a number of comments from different commissioners over the last few weeks, and I want to express our thanks for the work that you're doing. It's critical, and you do it very well. So we'll close on that note, and we'll look forward to our next board meeting on June 13th.
Thank you so much.
Thank you so much.